So, John, one of my favorite things to talk about is ridge augmentation. And because the question comes up all the time, do we place zygomatics, right, in the maxilla, right?
Short implants?
Or do we place short implants? Or in the lower, what type of ridge augmentation are we doing in the posterior?
Yeah, is vertical augmentation predictable in the mandible?
Do you use angled implants, John?
Right. So we figured we might want to bring someone on the show that could answer some of those questions. So here he is. And Dr. Buckley, thank you so much for being with us. Welcome.
Oh, thank you for having me. It's a pleasure to be here.
Yeah, we're excited to get to talk to you about this topic that, Wes, I mean, we've discussed, we've looked at a lot of the things you've published, we've heard from you multiple times at this meeting and others, and we're excited to talk about what's possible today. You know, obviously, in the last few years, we have seen the advent of sort of the short implant era, as it were.
Well, Mish said, and a couple years ago, maybe at the last meeting, he said, you know what? When I consider grafting, I first look to short implants.
Yeah, and that was a big change, we thought, as we started to hear some of the people that were big, graft people, quote unquote, who started to say, I'm actually looking more at short implants. But what that didn't change are questions as to what works with augmentation. So let's talk about what are some of the things that you feel like today you're most excited about that are changing, whether it be techniques, materials, that are changing the way we look at the ridge augmentation world?
Oh, that's a great question. I think that there's a lot of really exciting things in the world of ridge augmentation. I think that when you bring up short implants, grafting versus augmentation, everything we look at, we always have to weigh kind of the risk-benefit ratio. And in terms of when we weigh the risk of augmentations versus short implants, obviously in some areas short implants is better. Now, one of the areas, conversely, when we look at augmentation, one of the areas that I'm very excited about with augmentation is the reconstruction of the anterior aesthetic zone. So when we look at sites that have, especially now with some, implants are very successful, but sometimes implants do fail, and when they do fail, they sometimes can cause, especially across multiple segments, a severe vertical defect. And so in the anterior aesthetic zone, we have a lot of bone loss in the vertical area. There are a lot of exciting areas and how to regenerate that and to reconstruct it so that hopefully we may be able to give patients that are missing these defects natural-looking teeth without having to use pink porcelain and reconstruct natural aesthetics. So that's one of the areas I think I feel most passionate about.
So talk about that. Talk about some of the, we've seen over the years so many ways to do this, right? We've seen particulate grafting, and we've seen mesh, and we've seen blocks, and we've seen milled blocks, and we've seen everything, distraction, and so what's happening now? What are some of the things that you're going to and changing techniques or approaches? What should we be doing today?
So John, that's a great question. I think that when we look at augmentation in the aesthetic zone, we're talking about very delicate. We're really dealing with half a millimeter to a millimeter. You can do a significant augmentation in the aesthetic zone. Let's say you have somebody who has a 10, 15 millimeter defect, and you augment down to, let's say 10 millimeters, you augment down to 8 millimeters, and you miss it by 2 millimeters. You're going to use pink porcelain.
Right.
And so a lot of times, somebody said that if you're going to have to use a little bit of pink, why not use a lot of pink?
Right, get it out of the transition zone completely.
Why not spare the augmentation? So you brought up a very interesting observation. You said that there's a lot of techniques. You see a lot of different exciting techniques, sausage technique. You see distraction. You see, mesh, custom mesh. In the field of augmentation, when we see so many different techniques, if you were to go to a neurosurgeon and you say, hey, I've got a brain tumor, and he tells you, I've got 5 different ways to treat that tumor. You'd be really concerned, right?
Well, this is what I'm talking about. Like, I think you're in our wheelhouse because this confounds our mind, is how medicine has standardized certain procedures. Are we missing the standards?
No, I think that the augmentation works. So we have a number of vehicles, and we can get in a little more detail about some of the details on some of these, how these defects can be corrected. But these are all just vehicles. They all work. But the problem why there's so many different techniques is that they all have problems. When you're talking about vertical augmentation, especially today with the popularity of the use of biomaterial, you have to remember that biomaterial, you know, we call it a bone graft, but really it's just dead stuff, biomaterial. Xenograft, allograft, alloplast, all of those are essentially biomaterials, dead particles. When you put a dead particle into a site that does not make bone, it is not going to make bone. It's going to behave as a foreign body. It's no different than if I were to put some biomaterial, I cut a little incision in your muscle, calf muscle, and put it there. The wound will open up and invite it to leave. It's going to fail. So when we look at augmentation, in terms of techniques and protocols you always have to look at osteogenic potential. What is the ability of that site to make bone? Now there are sites, I think that in the field of implants and augmentation, we oversimplify everything. We make everything, the world, too black and white. You know, this is a horizontal defect, I do this. This is a vertical defect, I do that. The world, we live in a gray world. We don't live in a black and white world. So some defects and some patients make bone. The little, the strong, young, 18-year-old wrestler athlete, he's got a lot of muscle, he's got exostosis, he makes bone. You can do anything on him, he's going to make bone. You got the 75-year-old little old lady with osteoporosis who has no bone-making ability. She's on bisphosphonates. She's got a little diabetes. You throw the kitchen sink on her, you're not going to make bone. So we live in a gray world. And so we have to, in the future, we'll be able to identify some of these patients. Now, we do have techniques to be able to make bone and increase osteogenic potential on some of these patients. But we just have to be able to, there's no set protocols. So going back to osteogenic potential, once we identify patients that have, and sites that have osteogenic potential, then you ask the question, what is the technique that I should use to increase the osteogenic potential? So is this a technique that I can use biomaterial? Is this a technique that I should add some type of growth factors to increase osteogenic potential? Is this a technique where I need to increase the number of cells, transplant cells, to increase the number of cells and include some type of factors to induce those cells to grow? So I think that bone augmentation, especially when you're talking about these significant defects, involves a very tailored and very specific treatment for those patients. It's not a one-size-fit-all, and it will never be a one-size-fit-all.
So the biologics have been an interesting discussion over the years. It seems like when we saw the advent of, say, BMP, it was miracle grow for bone. We were going to do, it was going to do everything for us. And then there were some publications where it did some things for us, but then it had some limitations as well. Where do we stand now in the world of biologics, and how are you using those in your world? And what do you think the research is kind of heading us toward as far as the use of that compared to where we were in the last few years? So,
with BMP, I think that it's been one of the game changers, I believe, in the field of regenerative medicine. There are many, and I was fortunate to be one of the first people to use BMP early on when it first came out. When I was, when we were working at USC County Hospital, it was free for us to just pick it off the shelf.
Free.
Free. I mean, these were
stuff.
at that time, 20 years ago, these were like $5,000 packages. We were just able to pick it up, and so. I was fortunate to be able to use it. Now, there are many clinicians across the world in many countries, many modern countries, that do not have access to this. So I was able to use that. I would say that it's been a game changer in many practices. How? Well, in the old days, we would have to use either if we have a site that's not osteogenic, it doesn't make bone, we would have to harvest bone. And if we have a significant defect, sometimes we have to go outside the mouth, like the iliac crest or the tibia, to harvest bone. The availability of BMP has eliminated the prospect of me having to go to the hip I haven't had to open a hip. I was speaking at the Osteoscience Foundation last weekend with Bob Marks, and who's one of the pioneers at augmentation, and he said the same thing.
Eliminated that need.
Eliminated. And if you talk to some orthopedic surgeons, you'll find that in some areas of orthopedics, it has done the same thing. So I work at USC, so we do a lot of severe trauma cases. We do resections of benign tumors and continuity defect. And in some cases where a lot of these defects in the old days, we would have to harvest autogenous. There was no other way to provide that scaffold and those cells. And now we can use some type of a scaffold construct, like a biomaterial, like an allograft, and combine it with something to induce the cells around the native bone with the scaffold and form bone. And so we haven't had to use autogenous bone. We haven't had to go to the hip for many of these cases, I would say. Now, there are instances where we still do, but I would say that it has eliminated that in many, many cases. And this is true in many orthopedic practices also. We're having to go open the hip.
That's a major change.
Yeah, so that's a major...
Yeah, that's a major... So the world of the biologics sounds like has been one of the major advances that you are seeing that's allowing us to do things we just couldn't do before. And in the aesthetic zone, like you say, when every millimeter counts, having that at your disposal is huge. One of the questions I think I have that is somewhat indirectly related to that is temporization in these cases, right? Because some of these patients are going through multiple surgeries. We might have 2 or 3 soft tissue surgeries. You might have a couple of bone surgeries. And we don't want to have something obviously bouncing up and down on this tissue and putting a lot of pressure on tissue. It's different if it's a single tooth space, but if we're talking about a 4 or 5, 6 tooth space, speak a little bit to how you're sometimes managing some of these patients to give them some teeth during this process. Are we resigning these patients to just being indoors for 6 months? You know, how are some ways that you're managing that?
Well, that's a great question. I love these questions. Looks like you've done a lot of research.
Well, I'll tell you what, John, what we did is we created a pandemic so people could have surgery.
That's right. That's right. Wear a mask.
That's right. We wear a mask.
Wear a mask. Right?
So, one of the things that I think that we know we're not supposed to keep, put pressure on the bone and the soft tissue and the wound while it's healing. One of the things we don't know that over the years that I've observed is that, especially in the aesthetic zone, is that tissue has the ability to settle. When you make an incision anywhere, there's collagen fibers that you separate that then form, that heals. And when it heals, oftentimes these collagen fibers that are normally parallel with each other, they form into a little ball, like a ball of yarn. And so that's why when you see somebody who's had an incision anywhere, you feel this little bump. So that's that collagen ball. And then what do they tell you? Massage it, put vitamin E, do all this and that. Try to get that collagen to reorganize and flatten out. And so, and that's why one of the reasons why when you have had a plastic surgeon will never do a scar revision like 2 weeks or 2 months after you had a scar. The wait for that collagen to reorganize. The mouth is no different. When you do surgery, when you do augmentation, when you do soft tissue augmentation, bone augmentation, there's a lot of collagen that reorganizes. And in the beginning, it contracts. Now, over time, it will slowly release over time, and then it reorganizes parallel, and then it settles. The problem is that for us as dentists, is that we are trained to fill holes. When we see a hole, we want to fill it, right? We're a class 2 hole, fill. Dentists don't like holes, patients don't like holes. So when you leave a little hole, so when I do a surgery, I usually release, and I want that collagen reorganized. I know it's going to happen the next 4 to 6, sometimes a year. And I want to leave a hole. But the dentist is going to say, well, how come this is black hole? Let's go ahead and suck that thing right up into the gum. That tissue will never come down. And so what we've seen is that we have to create some type of prosthesis that hides that hole. So there is a hole, but sometimes the Esthetic is a good prosthesis, and also some type of a ridge lap that overlies the ridge but does not touch it. So most of these, when they're delivered to me, I make sure that there's not that many holes. But if there is, I tell the patient, we don't want to touch this. But if it's a stay plate, they cannot chew on it. If it's a state plate, then I reduce it completely, but nothing can touch it. This is the other area that I think is very exciting in the field of reconstruction in the aesthetic zone. Is that a lot of times we don't know right now, how long it takes for this tissue and when and which patients for this tissue to come down. When we're talking about millimeters, when you're off by half a millimeter or a millimeter, it's that there's the difference between success and failure. So I think that this is an area of research, an area that in the future we can look at. It's an exciting area. I think that we have the ability to, now most people temporize for, a few months. I've seen cases where I've documented where some of this tissue can take up to 2 years to settle. And so I will now work with a very good lab, make a very nice provisional that the patient can wear and is acceptable, and the patient sees that and says, hey, that doesn't look too bad. I can wear this for a year or a year and a half. And then we take photos. We don't tell the patients what we're waiting for because we don't want to set up expectations. And then we continue to take photos. And most of these cases, you do see the tissue settle vertically.
And so when you talk about that from a time frame standpoint in temporization, assuming that you are able to achieve the augmentation that you desire, when are you telling a restorative dentist to start sculpting tissue? Knowing that we could have a year potentially for collagen to reorganize and settle. How soon after, again, assuming that bone is where you want it, soft tissue is where you want it, do you say, okay, it's clear for you to start creating your ovate pontics or whatever it might be that you're trying to accomplish, or getting into implant, tissue sculpting? What does that look like?
That's a great question, John. It depends on how many surgery procedure was done on that site.
Okay.
So the desire, there's two things. One is the surgical outcome, the aesthetic outcome. What are you trying to achieve? If you've achieved symmetry, you've achieved enough architecture, you can go straight to final. The second is, how many surgical procedures. A lot of surgical procedures often cause, the more surgery you go in, so some of these complex cases, I'm going in 2 or 3 times. I've created a lot of surgical contraction. Those cases, in my experience, you have to wait a minimum of at least 6 months. A year is not uncommon. So people that go to my lecture, I always put the dates of this is the when we first temporize, this is how we're following these. And sometimes these take up a year or 2 years. But patients are always impressed at, oh my goodness, I thought, after 4 months, I can go to the final. But you showed the tissue settled 2 millimeters, 3 millimeters more by just waiting. And so I always wait until depending on how much surgery was done, that gives me a ballpark. If I've done a lot of surgery, I know there's a lot of contraction. Then I know I wait a little bit longer.
Certainly surgery's not over really until the prosthetics have been really completed.
That's right.
Because it's impacting the surgical site. And, I think that probably has been a game changer in our practice and how prosthetics can, one, aid in surgery and destroy surgery. And I think that's one of the things that the AO has done really nicely is marrying the restorative portion with the surgical portion, because the surgeons realized, hey, we need to raise the level of our pros guys so that they can help us do this, because we don't want to do pros. We want to do surgery, but and I think the surgeons realize, hey, we can use pros to actually help us out. Otherwise, it could destroy what we've... How has that changed in your practice, working with... you're talking about doing some of these things yourself, and our surgeon, he's like, I have to do some of these things myself. When we go to our surgeon's office, he's saying, Wes, can you go in here and, help me out with this? Because I need some...
Adjusting a provisional or whatever it might be.
How's that changed in working with restorative doctors?
That's a great question, Wes. Very, very intuitive. So, yes, the AO is a great community for this. I think that we're still in this learning process. In my practice, I've really refined my practice to working with some of the best people in the industry. And so I have the opportunity to work with some of the best technicians, Naoki Hayashi, some of the guys that are just at the forefront of knowing, understanding how to sculpt and how to make these restorations. I would say that that's probably 80% of the game. And you know, I think that I, as a surgeon, need to know what my restorative and my pros guys do, and I need to learn all of what he knows. I don't need to do it. I just need to know as much, and he needs to learn as much of what I need to do. And so from that standpoint, I think it's been a great learning experience. It's a continuous learning experience. I've been doing this for over 20 plus years in the same practice. I'm still learning. I'm still trying to figure out, you know, at what point do I stop, or when, how I can improve the results. But yeah, it's a great this relationship. It's an ever growing relationship, and then you have to have a love for it. And then that's why most of the people here at the AO, you have to have really a passion and desire to come to these meetings and learn about what the other guy's doing.
Yeah, so what defects, when going back to the pink porcelain discussion, when do you look at a defect and you say, nope, this is a pink porcelain case?
So, you know,
that gets to the pride.
Because obviously we can do a lot, as you're saying. We can do more than we ever could. Does that mean that every defect is treatable? I mean, or is there a point where we're down to basal bone and you're looking at this going, I don't know about this case. Maybe we should just keep everything out of the transition zone and not take risks.
Yep. So absolutely, a very good point. So there's three things you have to look at. Patient factors, meaning smoker, diabetic, on medications that
systemic disease.
So patient factors. Take them aside. Next is site factors. Some sites are much more difficult than others. In other words, they are scarred. They have been multiply operated. They have had a lot of bad bone, bad tissue. That's another one. And then the last one is surgeon factor, or the clinician factor. We know that different clinicians have different success rates. So those three things taken together. So it's not a one-size-fits-all. We don't live in a black and white world, as I said. So this question is asked to me a lot, and I have taught CE for 20 years. And I tell them that. I say, are you up to the challenge to do this? And if you are, if you do have the right patient and you have the right site, is the surgeon the limitation? So I would say that pink porcelain is always the first option. It should always be the first option.
That's good.
The reason why I say that is that the majority of people do not have the resources, meaning they don't have, I live in Los Angeles, in California. I have some of the best technicians that I work with at my around me, and I have some of the best prosthodontists. And I have people that are just passionate about it. They want to make that, and in some areas of the countries, you don't have that. And so the surgeon factor is out of the question. And then you don't have patient, maybe the patient, you may have the patient and the site, but you don't have the resources to do that. Now, having said that, I would say that in my practice, we rarely use pink porcelain, no matter what the defect is. So it could be a significant, defect from 6 to 11, 5 to 10. We're able to, if there are no patient factors, the site factors essentially just gives me how difficult it's going to be. And I always am very, all failures are failures of expectation. There are no success in failure. There are only expectations.
True.
I tell you, you're going to have pink porcelain and the graft is going to fail. And I made a graft that failed. You said, hey, you told me that this is the procedure. So all failures are failures of expectation. So typically, it's just how you manage the expectation. So I always tell each patient it's 2 steps forward, 1 step back. We're talking about these procedures, 2 steps forward, 1 step back. And if a patient that does not have any medical problems, I think in the area at this point right now with vertical augmentation, we're able to achieve a pretty nice aesthetic result, or at least a natural that where the patient is accepting of the aesthetic parameters that are there. I think we can achieve that in most patients, not all patients. And there is a stepped process towards doing it. It's not a one size. I see too many, I think, commercials of people thinking that there's this protocol, there's this guy, there's this guru. And every 10 years, there's 5 years, 10 years, there's always a new technique, a new way to do this. I think that's the wrong approach to all of this. When we're talking about 0.5 millimeter to 1 millimeter, 80% is just getting it there. No, 20% is getting the bone. 80% is creating that natural aesthetic. That's the difficulty. So you can have a fabulous technique, bring it down, and still use pink porcelain because you had a terrible lab or you had a terrible...
Absolutely.
I think one of the things that I'm hearing from you, and John and I love this stuff too, is the ability to talk to patients that expect not to have pink porcelain and setting the expectation. And as dentists, you know, we have this personality type that's very technical, and we're just driven to nitty-gritty, half millimeter here, millimeter there, and just pare down and neglect maybe the patient side of things. And I can tell you're very good at talking to your patients. And I think one of the things that I spend more time on with my associate is how to talk to our patients about setting expectations. What are you doing right now with some of the people you're training? And how are you working with people and teaching them to work with people? Because that's a side of dentistry that we just don't really talk about.
We talk about implants are forever, right? That idea. And, you know, we've heard this discussion, you know, oh, it's something you present to patients, it's forever, we'll just spend this money and you'll be good to go. And the patient has this expectation, whereas in medicine, they seem to do a little bit better job, you know, of calling things, we may need a revision down the road, right? Plastic surgery is very good at that. The word revision, that's normal in medicine, and yet for us, it's like that's a failure for us. So yeah, especially with training, how are you training people to talk to patients about, especially these more complicated cases, to set those expectations? Yeah,
that's you know, very, very, very interesting, a very good question.
How did you learn
it? Well, I learned that from years of failures, having my own failures. And when you have enough failures, you realize that, you know, the practice of implants is that, you know, for every failure, it takes about 3 or 4 other procedures just to make even for it. So how I set the expectation is that my staff knows, you know, that when we do a procedure, we tell patients that even if I place an implant in a native site, the success rate is about 94%. I said, that's pretty good, but it's not 100%. But it's pretty good. And when we do procedures, same thing. It's not 100%, but it's pretty good. And so the expectation is always is that these procedures we're trying to match what God gave you. We can't do that.
Right.
I'm no God.
Right.
And there's no procedure that can do that. But I'm going to do my best to try to match or create something that is acceptable for you. And many times we fail because medicine is not an exact science.
See, that's honesty, right? And I think patients kind of feel that honesty, and therefore whenever you feel honesty, you extend trust.
That's right.
Trust is earned and not given.
That's right. That's right.
And so when you are honest, hey, I've had failures, and this is what I expect, then they're like, you know what? This guy's not afraid to tell me what I really need to hear.
Well, and I think that's in our world of the fast-paced, want-it-now approach. And I would think LA would be the forefront of that in many ways, right? Yeah. It's, you know, I want this done now, and I want it to be perfect. And, you know, I think I remember Uli Grunder years ago, you know, at this meeting just saying, you know, I have no problem. Like I just tell patients, you're going to have nothing here for 6 months. And if you're not okay with that, I'm not your guy. And that's, you know, that's okay. I don't have to do surgery at everyone. And so we have to maybe reframe the way we talk to patients that it's not immediate and it's not now and it's not perfect.
That's right.
But like you say, if you have the right training, then we can set an expectation and hopefully we can actually back that up with, you know, getting where we expect it to go. But yeah, like you said, years of failures will teach you more than anything, I suppose.
Yes, more than anything. I think implant as a commodity has been oversold and has been commercialized to the point that, like I said, although it's extremely successful, but I think that we have to be careful that we, you know, patients go turn on the TV and they see, you know, implants are forever, implants are successful, and the practices guarantee this, guarantee that. You have to be very careful with that, and that there's nothing in this world that's guaranteed. I always tell patients, you can buy the most expensive Ferrari or Rolls Royce, it's not going to last you forever because these are wear and tear parts, and over time, the most expensive Rolls Royce will need to be maintenance or have to be repaired and all that. So same things with implants. There's nothing, and you have to remember also, the last point probably is that we treat patients that are very dynamic,
Yes.
that are ever changing. A patient today that may not smoke might smoke in 10 years. A patient that has good hygiene today might be in her 80s, might not have the same hygiene, might not have the same manual dexterity.
That's right.
So things can go south. And so when patients ask me, what the expectations are, I always, very honest with them. I say, it really depends. It's a very constant state of flux and change. But we can do say that we will provide you a good quality of life and function for the next 10 years, and that has a very high percentage of that being achieved.
Hey, if you're listening to this and you don't want pink porcelain in your mouth, well, I know where to go.
That's right.
At least I know where to start.
Exactly.
Right? And I start with someone like yourself, sir.
Yeah, thank you for being with us.
Yes.
And it's been a great conversation and
Yeah.
just gives us a lot to think about as far as how to not only what's possible with augmentation, but also just more of, how do we establish those expectations? Because if we're going to do it well, it's going to take some time. It's going to take some work. And it may not be perfect, but we're getting there. We're getting closer to that.
We're getting closer.
Yeah.
We're getting better.
Yeah. Well, thank you very
you
much.
You guys
so
are
much.
awesome. I really enjoyed these. These are
Yeah.
really well
Yes.
thought out
Maybe we'll
questions.
do it in the future.
Yeah,
Yes.
awesome.
Absolutely.
Yeah, very, very
Absolutely.
nice. Thank you so much,
Thank you so
John.
much for
Appreciate
joining us. Yes.
Appreciate it.
Thank you, Dr. Lee.